Hello everyone and welcome to INEDCAST, your go-to podcast for in-depth discussions on the latest breakthroughs and expert insights in hepatology and gastroenterology. I'm your host Dr. Sanjay Sarpathy and I'm thrilled to have you join us today for this special episode. Earlier we had the privilege of listening to an outstanding lecture by Professor Annalisa Berzigotti, one of the foremost experts in the field of hepatology. A lecture titled Portal Hypertension Bleeding, Risk Stratification, Diagnosis and Management provided the state-of-the-art overview of this critical topic, highlighting the latest advancements and practical strategies for managing patients with cirrhosis and portal hypertension. But today, we are diving even deeper. This is your chance to gain more insights from Professor Berzigotti as he answers some pressing questions submitted by our listeners and attendees of our lecture. For those of you who may not be familiar, Professor Berzigotti is a distinguished professor of clinical hepatology at the University of Berne and serves the Chief of Hepatology and co-director of the Department of the Visceral Surgery and Medicine at the Inselspital University Hospital of Berne in Switzerland. Her career began in Bologna, Italy, where she completed her medical education and residency, followed by specialized training in liver disease research at the Hepatic Hemodynamic Laboratory in Barcelona, Spain. With over 300 peer-reviewed publications to her name, Professor Berzigotti has significantly shaped our understanding and his management of cirrhosis and portal hypertension. Beyond her academic achievements, she has been a leader in hepatology, serving on the governing board of the European Association for the Study of the Liver, the Council of the United European Gastroenterology, and the vice chair of the Baveno Cooperation, an EASL initiative advancing portal hypertension research. Her accolades include the Stern-Gaddicott Prize in 2018 and the Lucy Bolt Prize in 2021, recognizing her exceptional contribution to the field. With that introduction, I will take you to the Q&A session. Dr. Berzigotti, that was a fantastic, truly an outstanding talk, and such a comprehensive overview in such a short time, like in 1 hour. I don't think anyone else could have done other than you.
No, I don't think so. There are many people that can do it, but I did my best. Thank you.
But I would like to now invite Dr. Prasun Jalal to co-moderate this session. And Dr. Jalal, and who is, please introduce yourself, Dr. Jalal.
Thank you. It's an outstanding talk. In fact, I was reading the comment from Dr. Colombo from Milan saying that it's an outstanding talk. Thank you. I echo the same thing as Dr. Sarpathy mentioned, that I don't think within such short time you can encompass so many areas in this area of portal hypertension. I'm a faculty at Baveno College of Medicine, Houston, Texas, and transplant hepatologist. Thank you again. So I will start the question first while waiting for other people. Thank you, Sanjay, for arranging it. There is always some a comment we get from our trainees. If you band the esophageal varices, does it increase the gastric variceal pressure and more chance of bleeding? Vice versa, when you obliterate the gastric varices, do you see more risk of bleeding from esophageal varices? What's your take on that?
Well, that's I would say a common observation. The data is scanty, so there is not really a strong evidence that tells you cannot do banding if you have also gastric banding of esophageal varices if you also have gastric varices. But I think many endoscopists refer that they had a worsening of either one when they did something on the other district. I think that it cannot be taken as an obvious assumption because it depends very much on the degree of collateralization. So if it's very, I think, patient patient specific. So what will be the behavior of varices in that specific situation, I think is not really generalizable, I would say. So I cannot give you a strong message in this sense. I think you have to go with the evidence and treat varices according to what is needed in the moment when the patient is presenting to you.
Great. Thank you. Now we'll wait for comments from other people.
Well, let me invite, there are some stalwarts here, Dr. Massimo Colombo, then Dr. Dharmesh Kapoor. Let me invite Dr. Kapoor. Thank you for time, Dr. Kapoor from India.
Good morning to you, Sanjay, and this was exhilarating to say the least, and I completely agree that it's impossible to cover this vast topic in such a short span of time. Just goes to show that Professor has probably spent all her life doing this. It was almost like, a story being told. So fantastic. So the question is that, for many years before the NITs were available, the emphasis was always on that population which would not respond to non-selective beta blockers. So when I was in training, there used to be a standard statement that only about 20 to 30% of patients will respond to beta blockers, the others will not, and you can describe that acutely by doing the HVPG studies, and another 15 to 20% would have adverse effects due to beta blockers. Now, in the era of NITs, what would be your take on this cohort? So I know you made a very provocative statement whether the NITs would also decide our usage of non-selective beta blockers in future. And there are naysayers, and there are those who say that yes, that probably might be the right thing to do. But what would be your take on how to assess the response to non-selective beta blockers?
Yeah, that's a very good question. So I think there have been many things that changed in the last 20 years. And so, of course, knowing whether a patient responds or not to beta blockers remains important, but we nowadays use a type of beta blocker, which is carvedilol, that achieves a response in over 75% of cases according to the data, which means you are left with a relatively low number of non-responders. Plus, if you start early in the natural history of disease, you have more response. So the question might be still very relevant in decompensated patients, so after a first bleeding. However, after first bleeding, you also ligate the patient. So you use two treatments, beta blockers and band ligation. In primary prophylaxis, starting early, you achieve a response in the vast majority of cases. So whether you really need to know whether the patient is a responder or not, maybe is a bit more a speculative aspect than a reality, first. Second, at the moment, we don't have really strong non-invasive tests to assess response to beta blockers, but there is some data regarding the use of spleen stiffness in this sense. There is a very nice paper published some years ago by a colleague from Korea on this with an independent cohort showing that a decrease in spleen stiffness during the use of non-selective beta blockers was associated with HVPG response of over 20% of decrease in portal pressure. So probably we should try to validate externally this data and see whether this is already a test that we can use. Plus, there is a lot of research on other type of non-invasive tests, in particular imaging tests, to be let's say more exact and refining the availability of a test measuring pressure non-invasively, so not just threshold or whatever, but a number. And there are good developments that probably in the next few years will become true with contrast enhanced ultrasound for this specific aim. So I do think that first we will go in the majority of cases with a strategy based on non-invasive tests. There is also a recent paper looking at Markov models and showing that this is also cost-effective for the society. And in moments of restrictions of say, finances everywhere, we should also think at this aspect. So if you can benefit or reduce the risk of a patient in a pragmatic way, probably this is the right way to go. in a subset of patients where you really need to know and to be exact, we still have the gold standard, we still use it. So the H3PG is still an excellent tool that needs to be used in the right group of patients where you still are in an uncertainty situation, or if you have to be very precise in the determination. For instance, in some instances of patient pre-surgical or patient with ACC that needs to be selected for a resection. So you still need the best reference standard for some specific situation, but I don't think you need it in all.
Thank
and
you.
very, very quickly, Professor, can you ask you what's your take on primary prophylaxis with endotherapy?
When endoscopic therapy?
Yes, with endoscopic therapy, because again, to me, over the years, it has been that it's a low-lying fruit, and especially fellows in training, when they see juicy varices, someone has bled or not, they would just jump at the idea of performing band ligation. So what's your own take on this?
I think to your fellow, you have to explain that having had or not a bleeding changes completely things. So if you had already a bleeding, endoscopic band ligation is clearly indicated in association with in combination with beta blockers. So they have to do it. If varices are large enough to be ligated, they have to be ligated until eradication. So this has to be repeated until varices are eradicated. If you are in a primary prophylaxis, so if the patient never bled, you have time enough to think. And so our take is, if you diagnose varices, even if they are large, we start with non-selective beta blockers, and only in patients who have either a contraindication or they don't tolerate beta blockers, we go to endoscopic band ligation. And this is, in our view, ethic, also because we are looking, I don't know if you had the chance to taking a look at this, but we are really analyzing a big complication and a beta orphan complication of band ligation, which is ulcer bleeding, post-ligation ulcer bleeding, which is a dramatically bad complication with a mortality that even in recent series is up to 30% of cases. So it's exactly the mortality that variceal bleeding had before we had the right treatments. Now there is no standardized treatment of bleeding due to post-ligation ulcers. So we are scared about, they are rare, it's true, but when they happen, they are really a scary complication. And therefore we think that is correct to try to offer the patients a medical treatment before endoscopic treatment. And if you cannot go on the medical treatment, then fine, of course.
Thank you so much. Exactly the point one wanted to drive home. Thank you so much.
So there is a question from Dr. Mangesh Pagadala. I know everybody has to go to clinic after the liver meeting. Everybody's back. Dr. Pagadala from Dallas.
So Professor, thank you very much. That was a great talk. And since you focused heavily on non-invasive markers for variceal risk, my question is kind of pertaining to that. So, we usually do not do fiber scans in patients who have ascites because you don't need to. They already have cirrhosis. And we know that ascites forms in a lower portal pressure compared to a varices. Has the Baveno 4 criteria taken into consideration the false positives, the negatives you get out of fiber scan in patients with ascites?
So I just repeat my first concept. All that I said relates to compensated patients. If you have ascites, you are in a decompensated stage, and endoscopy to look at varices in decompensated is clearly indicated because these patients have a different type of situation. And so if you see ascites finished, you are in a decompensated stage, and these patients need to be looked with an endoscopy. So that then you don't need fiber scan.
And does statins affect the Baveno score?
Sorry, I didn't get it.
The use of statins.
Yeah.
Because it decreases the nitric oxide regulation and things like that. Mm-hmm. So would that affect the Baveno scoring, especially in patients in NASH? Many of them are on statins. So just curious about that.
There is no data on liver stiffness before and after statins, but I would think that since the effect is not on fibrosis and is on microscopic vasodilatation, you probably would not see a big difference, but there is no data. So if I have to be really evidence-based, I cannot answer your question.
All right. Thank you so much.
You're welcome.
Thank you. There's a question from Dr. Nipun Verma. Why didn't you ask your question? He is from PGI Chandigarh in India.
Hello, madam.
Hello.
Thank you very much for the nice presentation. My question is, which drives the decompensation? Is it the systemic inflammation or portal hypertension? Or is it the combination, or is the relative combination is different? So I think there is some evidence to suggest that systemic inflammation is a major driver in acute decompensation, and all variceal bleeds are acute decompensation. So I'm a little bit confused. So, and which one to target, and does it really matter?
So that's a nice question. It's a bit complicated because I think what you mentioned is correct. So systemic inflammation you are mentioning in acute decompensation or in acute or chronic liver failure plays a role. For instance, when you have a bacterial infection, you have a systemic inflammation, but both are true. So if you have a systemic inflammation, also portal pressure will increase because part of the effect of the systemic inflammation will so somehow even increase the pressure level. So what is clear is that decompensation is favored or is driven by presence of portal hypertension. So you somehow need to have high portal pressure to then decompensate. But what determines exactly the moment when you decompensate is not yet completely clear. It's a matter of research nowadays, and either systemic inflammation or translocation through the portal venous system from the intestine, so the let's say microbiome related dysbiosis story and leaky gut is indeed one of the pathophysiological mechanisms that are thought to favor the onset of a first decompensation. But this is still a matter of research, is not at all fully clarified.
Thank you so much. Thank you so much.
So I think there is another question about the type of beta blocker depending on the portal vein velocity measurement. I would ask this, the physician to ask the question himself, if you can. Okay. So yeah, the question is, portal vein velocity has any role to decide on the type of beta blocker?
No, does not play any role. So usually in patients who are still compensated, portal vein velocity is a bit decreased, but is not usually a dramatically decreased velocity. And anyhow, beta blockers are not prescribed looking at portal vein velocity. So you still use the clinical recommendations that we just reviewed today. Again, the beta blocker of choice nowadays is carvedilol, and is carvedilol even in patients with, I'll say, not fully compensated situation. So in the past it was said, well, in compensated it's perfect, but since it can decrease a bit arterial pressure, don't use it in patients with ascites. We have now data also in patients with ascites seeing that it is a safe medication. Of course, you have to be careful if you have patients with a very dramatic decompensation or decrease in arterial blood pressure already at baseline. And then in these cases, please check the Baveno recommendation, because there is a very clear description of what you do and not do in terms of beta blockers. We don't have time to go into all details on that. But then the beta blocker of choice is carvedilol. You can still use propranolol. For instance, what we do sometimes, if a patient is intolerant to carvedilol, we try propranolol, or vice versa. If the patient was on propranolol for the old times, we usually try to shift to carvedilol. But carvedilol is very well tolerated and easier to manage than propranolol. So nowadays, I think just go with carvedilol.
Dr. Berzigotti, I have a follow-up question to that. Just to clarify to our audience, the target heart rate, not heart rate, target blood pressure with correct is 100, correct?
So let's say we say don't go below 100 millimeter of mercury of systolic, or you can use the mean arterial pressure calculation. But let's say, yes, usually we check arterial systolic blood pressure, and we try not to go much below 100 millimeters of mercury.
And we don't go by the heart rate as
no, carvedilol, interestingly, carvedilol does not decrease heart rate as much as propranolol, because it decreases a bit the arterial blood pressure. There is a compensatory increase in heart rate. So from one side it decreases it, but from the other one it decreases. So you cannot use heart rate, and that's why also it's easier to manage carvedilol, because we have fixed doses. So either you can use the full dose, which is 6.25 milligrams twice per day, or if the patient does not tolerate this dose, you stay with the lower dose, it is the half. Basically, it's a very easy to manage medication.
And you mentioned with ascites, don't use a beta blocker. Like, is that?
No, you do. You have to use beta blocker, yes.
Okay.
So with ascites, if ascites is a non-complicated ascites and blood pressure is okay, and the patient does not have spontaneous bacterial peritonitis or hepatorenal syndrome, data in meta-analysis are clear and show a benefit of beta blocker exactly as in the other patients. So please use beta blockers also in your patient with ascites. These are more fragile patients, so you have to manage them in an even more detailed way and look at their arterial blood pressure and avoid dropping below the thresholds that we just discussed. But else you have to use beta blockers in patients.
And one other question, with the advent of endoscopic techniques such as portal pressure gradient measurement by US guided approach, which is a direct portal pressure measurement, do you think any advantage over HBPC measurement?
So, you know, this is still a question mark, because despite I know that many centers use it because it is available, there is no data on that. So the data is very scanty, and head-to-head comparison with HVPG are still ongoing. So we do not know if indeed the thresholds are the same, if it is as effective as the HVPG in predicting bleeding or other type of events. So I think we have a bit we have to be a bit careful on that. I think it will find its application and its role probably. So if it will be validated, then it could be done in patients that cannot tolerate other type of measurement or who need endoscopy anyhow. But I would be a bit careful. So we cannot say that is already a standard of care. We do not know what we are exactly measuring when we give a value with that technique. So possibly it will be an excellent tool, but we need to wait for the data.
Thank you so much. I'll invite Dr. Colombo now, Massimo Colombo.
Good afternoon, Annalisa, and congrats. It was a really outstanding talk. I learned a lot. It was a good investment to me, of course, as usual. My question is, trying to shift to a more familiar area field for me, like liver cancer. Clinical decompensation is a driver of mortality in cirrhotic patients with acute liver cancer, which can be manipulated to some extent in those with a treatable etiology, alcohol, autoimmunity, viral hepatitis B and C, less effectively, of course, in MAFLD-related liver cancer cirrhosis. So the question to you is that possible to envisage a combined therapy with starting, of course, I believe, according to the papers you quoted, and perhaps more efficiently, of course, with carvedilol, and demonstrated that even in the domain of liver cancer-related disease, you can achieve an increased survival by preventing clinical decompensation?
This is an excellent question. I think in general, it is foreseeable. So if whenever possible, treating the underlying pathophysiology of the underlying liver disease should provide benefits, also maybe in terms of lack of recurrence of cancer. We know that some of these drugs have also anti-cancer property, right? And preventing decompensation is of course very valuable to these patients anyhow. So the problem is what happens then to the natural history of cancer, because many patients decompensation is related to cancer per se, no? So they have an increase in port. So if they are cured from their neoplastic disease, you mean completely cured, then I would say that of course they should be treated even probably more aggressively for their underlying liver disease than other cases. So statins, yes, beta blockers as well, and beta blockers have also this great.
And, Annalisa, I also quoted statins that, the post-hoc analysis of randomized controlled trials were not able to demonstrate any prophylactic activity with respect of liver cancer per se. But you have alluded that, common friend of ours, Vincenzo Lamura, statins, the story of statins versus the compensation.
Yeah, so I think we have now several tools that can be used, and they should be used in combination, the maximum. And MASLD, it's true that it's at the moment a more difficult disease to treat, but many drugs are entering into the field, and some of them have really very potent antifibrotic effects, and cancer at the end and decompensation depend on the fact that fibrosis is going on in these patients. So if we can reverse fibrosis in them, and there are really now some classes of drugs that are amazing on this, probably we will achieve a situation that we could not foresee in the past, that is full regression of cirrhosis, and then full regression of portal hypertension, and then no risk of decompensation. And you are an expert in hepatitis C, so you know that when you achieve SVR after some years, you can achieve full regression of cirrhosis, and then portal hypertension is no longer present, and these patients have long-term survival without any event of decompensation. So I do think that this should be what we do in all etiologies, and MASH probably will also belong to this. And GLP-1 analogs will help us by reducing body weight, but not only them.
Can I put forward another question to my friend Annalisa? I want to take advantage of her generosity. Annalisa, in the domain of MASLD, let's say, NITs proved to be very effective in the risk stratification with respect to prognosis, including decompensation, liver cancer. My question is, when they design trials or try to design comparison between, let's say, approaches, qualifying the outcomes of NIT test in terms of F1, F2, F3, F4, which in my opinion, was originally designed in trials enrolling patients with viral hepatitis B first and non-A, non-B second, which, however, miss in my opinion at least, tell me if I'm wrong or right, miss the pathophysiological, strategically important histological figures of pericellular fibrosis, which drives the prognosis in your portal hypertension, the compensation, and why not cancer? So do you think that all these studies that are comparing, the NEAT and qualify in terms of F1, F2, F3, so METAVIR, in other words, should be requalified with histopathological investigation, pinpointing the role of pericellular fibrosis?
Definitely, but I would tell you even more. I think that now the evidence is so strong in terms of ability of non-invasive tests to prognosticate that we will move away from liver biopsy, at least in patients with clear-cut risk factors for a given disease. So I think we will even go away from trying to correlate a surrogate with another surrogate, because at the end, liver biopsy tells us a lot for diagnosis, but when we look at fibrosis, we are looking at a surrogate of outcomes. So at the end, if NITs are as good or even better, and there is good data that in MASLD are even better than liver fibrosis to prognosticate in terms of decompensation or liver cancer or even mortality, then why are we trying always to refine a sort of classification from a surrogate to another surrogate? Let's go directly and use non-invasive tests only as prognostic marker and not a diagnostic one. So I think we should move away from biopsy in this sense. Not for diagnostic too, that's a different topic. But for prognostication, I think it's time to abandon the idea, in my mind, it's a F2 and then the prognosis is that. No, stop, look at all the needs that you need and you prognosticate based on that.
Fully agree. Thank you so much. Fully agree.
Thank you. There's one question in the chat box. I think if I understand correctly, a lot of patients bleed from telangiectasia or GAVE or even portal hypertensive gastropathy. What's your take on effective beta blocker or tips on these patients?
So you are asking different things. So telangiectasias and GAVE are not complications of portal hypertension, and so beta blockers and tips are not really effective on this type of lesions. On gastropathy, there is good data showing that tips, in case of very severe gastropathy, which is relatively rare, but tips is an option. There are other options, pharmacological ones, less well known. For angiodysplasias and telangiectasias, there are data on octreotide, but it is irrespective of the presence of portal hypertension. So tips, consider it in severe gastropathy if you are really sure that that's the cause of bleeding of the patient.
The message would be, for if you have portal hypertensive gastropathy, you may consider tips or even blockers, but not for telangiectasia because it has no
There is nothing. If I can just tell you something that is based on some experience, whenever you have patients that really have big telangiectasia or angiodysplasias that bleed or strange lesions in the stomach that you are not sure about, please check heart, because there are many of these patients who have valvular disease that somehow has an impact of this. It gives a component of congestion on the liver, and if you then can solve it, patients stop bleeding. So this is something that we often underestimate, I think.
But do you feel that portal hypertensive gastropathy respond well to beta blocker or tips?
Well, yes, to beta blockers it does respond because there is some data on that. I tell you, I think the evidence is quite limited because there are not really huge series on gastropathy. There is one from Barcelona many years ago, but not many more focusing on that. Empirically, I can say our own experience with gastropathy, I think we have put 6 or 7 tips in the last 5 years for this indication after being very, very sure that that was the problem, and they responded. So they went well. They did not need any transfusion more after tips.
That's great. I think this is the last question in the chat box. It says that we use non-selective beta blockers for primary prevention. And if you're not doing the ligation in these patients, unless they bleed, why do you need to do endoscopy variceal surveillance once you put them on beta blocker?
Yeah, indeed, you don't need to recheck endoscopy. Once you start beta blocker in primary prophylaxis, please don't check endoscopy, because else you will not know what to do, and there is no guidance on that, and there is indeed no need to do it. So please just don't do it. Also because I don't know if you remind the data on the variability inter-observer on varices on endoscopy. So let's not discuss this because else it would be really a problem. So please just stay with the evidence that we have. So if you start with the blockers, you don't need to go on with endoscopic surveillance.
So one other question: any role you feel is the partial splenic embolization has in the treatment of refractory portal hypertension?
So that's a good question, and I think it is something that should be better explored because it's not much part of the algorithm of treatment in Europe or in the Western world, so even in the United States, but it is a very common intervention done in Japan and in some other Asian countries because they don't use tips. So in Japan, I didn't know, but in Japan, tips is not reimbursed, so they don't use it. And so they had to find other alternative, and they do regularly partial spleen embolization, and they state that the results are good. It has some pathophysiological, I would say, sense, because you reduce the component of flow due to the hypersplenicity, so the increase in congestion in the spleen. But we don't have good data in Europe comparing it to our standard of care. So I think it would be an excellent idea for studies, provided the colleague from Japan could give a bit more data on the HVPG results, etc.
So you think it may work, right, in some patients?
I mean, we have, in any reference center, sometimes you have cases that are not, you cannot treat according to the guidelines because they are out of the standard. And then if you have to be creative and you don't know what else you could offer the patient, you can also go to this type of treatment that has less evidence. But before stating, yes, let's use it, I think we need more data.
And then when we do the tips in gastric variceal bleeding, do you usually recommend them also to do embolization of the varices so that?
So that's something that is more evidence-based. So there are some technicalities that I will not enter into details, but sometimes even if you put in a tips, if there are very large collaterals that still flow away from the tips is not working properly. So to achieve a good flow through the tips and a good function of the tips, sometimes you need to embolize these very large collaterals. Plus, there is a recent study from Asia in very large numbers suggesting that those in whom you embolize the big portosystemic collaterals have an advantage in survival and do less encephalopathy. So potentially it is the case. According to the guideline, we do it in patients who bled, so in bleeders. We usually, when we have to put in a tip preemptive or rescue, we also embolize the varices, but we don't do it as a standard, for instance, in patients who do tips for other indications like refractory ascites.
Great. I think we can conclude now.